So Professor Peter Collignon is our speaker. He's already tweeted that he's a bit fearful for his life. He's currently Executive Director of ACT Pathology. He was previously Director of the Infectious Diseases Unit and Microbiology at Canberra Hospital, where he's worked since 1987. He's a professor at the medical school at the Australian National University, and his main research interests involve all areas of antibiotic resistance, influenza, bloodstream infections, infection control, and healthcare-associated infections, especially from IV catheters. He's been on many expert committees of the World Health Organization on the issue of antibiotic resistance and the use of antibiotics in food animals. He's been doing that since about the year 2000. He was made a member of the Order of Australia in June 2009 for his services to infectious diseases, microbiology, and infection control. Sit up straight, pay attention, and please welcome Professor Peter Collignon, AM.
Thank you. Well, thanks very much for having me as a guest, because I actually think this is a really important issue and that affects all of us. And I think a lot of how antibiotic resistance goes around and comes around is in ways that we don't always give credit for. I'm actually a practicing physician, and so I guess from my bias, I actually enjoy is the wrong term, but you get a thrill out of seeing people come very sick with a life-threatening illness. You can give them an antibiotic and they basically get better. And I guess one of the things that worries me about antibiotic resistance is that may not happen. Because if you think in the days before we had antibiotics in the 1920s, if you had a golden staph in your blood, for instance, there was a 85% chance that you'd be dead in the next 30 days. And if you had the pneumonia germ in your blood, there was a 90% chance. Now, antibiotics haven't reduced that to zero, but they've reduced the mortality to about 10%. And so when you have antibiotic resistance, that mortality rate goes up and people are sicker for longer and more people die. And I guess that's why I've got a view on this. Now, one of the things is we tend to actually get very focused in, this is, doctors like me overprescribing antibiotics, or somebody else says it's a food industry or whatever. I think what's really important is this One Health concept. I mean, whatever we do in one sector or in one area of the world has a chance of coming around and biting everybody else. And I think that's very true also for antibiotic-resistant bacteria. They just don't stay confined to one sector. Now, they may be more important and may circulate more in one sector, but at the end of the day, they go around. And I think one of the major ways this happens is through water. So it's really important that we, I think, give more consideration to water than we need to. Now, Australia, we're very lucky because we've got a very good water supply relative to most of the rest of the world. And I think it's one of the reasons we have lower antibiotic resistance than most of the rest of the world as well. But this point is that, there's numerous ways you can get antibiotic-resistant bacteria and they go around to other sectors. Now, Australia is truly the lucky country. We have very low levels of antibiotic resistance. And what's interesting about that, in people at least, we don't have low use of antibiotics. We're about the same as France and the US. We have twice the amount of antibiotics per head of population than the Netherlands, for instance. Yet we still have low resistance, and I might talk in people. I might also say in our food animals, we have some of the lowest resistance rates in the world as well, both in poultry, pigs and cattle on the limited surveys that have been done, and I'll discuss why that may be so. Now, one of the issues with this from an economic point of view, there's arguments that, large amounts of antibiotics are used in food animals. Probably 70 or 80% by volume of all the antibiotics used in the world are used in food production, not in people. And it's the same in Australia, at least. And even if you take out ionophores, it's still 70-30, even without ionophores there, which are antibiotics not used in people. But this is a large food chain in the US, and they make a point that they don't use antibiotics at all in the whole production of these animals. Now, I might say that's further than I think we need to go. I actually just think we need to use them sparingly and responsible. But there is, large food chains that are putting this up as advertising. And more there's contracts being let by supermarkets and stuff that make a point of at least limiting what antibiotics can be used. Just as another example, this happened last month. Purdue Chickens, which produces about 1 billion chickens per year in the US, and I think they also are involved in cattle and pig. But they actually announced that they will no longer use antibiotics in their hatcheries. Now, the significance of that is the US produces about 8 billion chickens a year. And every one of those chickens, before they're hatched, are injected with a vaccine at the same time as an antibiotic. And around the world, they were using a thing called a third-generation cephalosporin, which caused a lot of multi-resistant E. coli. So these people have managed to decrease their antibiotic use by 95%. They don't use it at all in hatcheries now, yet they're very competitive on the US market for poultry. And I might say Foster's, which is even bigger than them, last week announced something similar. So I think there is movement for lots of reasons that show you can do this without losing your production and becoming uneconomic. Now, my own view is antibiotics are miracle drugs. If you think about all the other drugs we use, at least in medicine, none of them actually cure anything. You know, you've got asthma, you take a drug, it helps it, but it doesn't cure it. If you've got cardiac disease and or you've got your cholesterol you need lowered, you need to take a drug, it gets it down, but it doesn't cure it. Antibiotics, you give it to somebody, it kills the bug, and you're cured. Now, the problem with that is twofold. First of all, I guess it gives us a great satisfaction to do that. The downside is, if you're a drug company, this ain't where the money is. We're much better off having a sexual drug that makes you feel better all your life, or a cholesterol-lowering drug that a lot of the population takes forever. And not only that, if a new antibiotic comes on the market, that's the great new wonder drug, the first thing is people like me get in the media and say, oh, don't use it because we need to use it as a reserve. So that's another great motivation for pharmaceutical companies. The end result of that is there are not new antibiotics coming onto the market for practical purposes. There's some Me Too drugs, but there's hardly any new classes that have come available for a long period of time. There is now a lot of political action to try and change that. The US president put out something a few weeks ago. The European Union, and even the G20, antibiotic resistance was on the G20 discussions when they were in London last year. So there is a lot of political thing, but I personally also don't think there's going to be a miracle solution tomorrow because there's not the money in it for the pharmaceutical companies. So what we have to do is preserve what we've got now. And there's no doubt that antibiotics stop people from dying and stop suffering, which we call morbidity. And the evidence for that in Europe, for instance, if you have a particular E. coli germ in your blood, and it's what we call an ESBL, which is extended spectrum beta-lactamase, but it means none of the cephalosporin drugs work at all, or penicillins. If you have one of those, you've got 3 times the chance of dying, and if you survive, you'll spend an average of an extra 5 days in hospital. So there is quite good data that these bugs are not good for you to have. Now, the 1920s was a great old time, but as I mentioned, if you're unfortunate enough to actually have one of these bugs in your blood when there weren't antibiotics, you had quite a high mortality. And these antibiotics, Florey, Fleming, penicillins, cephalosporins, macrolides, made a huge amount of difference. And so much so that I think in the late 1960s or early 70s, the US Surgeon General said, infectious diseases are a thing of the past. We've got antibiotics now, new ones coming. This will never be a problem. I guess that was before HIV, Ebola, and a few other things, but anyway. Now, how much resistance is there naturally? One of the important things is to realise that resistance is around everywhere. Antibiotics are made from fungi. For instance, penicillin, when Fleming found it, was because he went on holidays for a month to Spain, came back, and the obsessive-compulsive person he went through his rubbish, took out a staph plate, and saw the staph had been inhibited where a fungus had landed on the agar plate, and it produced something that killed the bacteria that were there before. And that's where penicillin came from the penicillium fungus. And lots of the other antibiotics we got are from natural bacteria or fungi in the environment that produce these antibiotics because they're trying to keep the turf for themselves and keep out bacteria. And all we've done is found these, exploited them, chemically modified them. But what that also means is there's natural resistance out there. Now, if you produce an antibiotic to kill the next door neighbour, you'll also produce the antidote yourself. And that's all genetic encoded, and it means it can transfer around. So just as an example, we did a study a number of years ago in kangaroos, and we looked at their faeces, and there were very low levels of resistance. ampicillin about 3%, and chloramphenicol, but it's not zero. Mind you, it was zero for a whole lot of the higher level drugs, and this was about 400 isolates. But in people at the same time, it was much higher, 46%, 28%. And that's a function. When you use antibiotics, you get resistance. Not surprising. The other issue, though, is resistance is rapidly rising. It's rising in Australia, but if you look at some of the other countries, they've got huge rates of really resistant bacteria causing serious disease. And as an example, this is Europe, they look at blood culture isolates. So these are bugs in blood causing septicemia. And fluoroquinolone is ciprofloxacin, one of the more recent groups of antibiotics that were released for human use in the 1980s. And as you can imagine, red is bad. So there's large amounts of resistance, more than 25, 50%, in the isolates causing bloodstream infections. And even in countries that are much better, such as the Scandinavian countries, the resistance rate is still 5 or 10%. And that's compared to very low levels, say 10 years ago or 20 years ago. For another one called ESBL, these third generation cephalosporins, again, red is bad, green is better. But this is a marked change over about a 10-year period. But we've got a lot of data from Europe, but where there is the real worry is the developing world. That's where resistance is, I think, particularly bad. And just as an example, you can't probably see all these figures, but in India, for instance, E. coli is the commonest cause of urinary tract infections. For practical purposes, half their E. coli are untreatable. About a third of them are resistant even to carbapenems when you do them properly, which is truly our last line antibiotic. That's a very expensive intravenous drug. So from my perspective, looking at these figures for a lot of Southeast Asian and Asian countries, most of the people are back in the 1920s. If they get the infection, they get either better by themselves or they succumb. Now, as much as I hate to say it, people do get better without doctors. People did get better in the 1910s too. But there is a lot more suffering than needs to be if you've got too much resistance. The real scenario, this was in The Lancet a couple of years ago. In India and Pakistan in particular, but it's also been found in Vietnam, there are varieties of resistance encoded by a gene called the New Delhi metallo-beta-lactamase. But what that means, it's resistant to all penicillin cephalosporins and the carbapenem, which is the last line antibiotic we've got. And it's in the waterways. And not only that, the genes are spread not only from E. coli to Klebsiella, but to cholera and to just about most bacteria, because they're in this environment where they're all together and bacteria are very good at exchanging genetic material. And these organisms have come back to England and caused problems in hospitals there. And we've had one patient in our hospital who came back after elective surgery that went very badly wrong in India, and they did it because it was cheaper, with a gram-negative bug that was resistant to every antibiotic, including experimental ones. So these things exist. They're luckily, from our country, they're rare, but they're not rare in places like India and China and Pakistan. The other thing is we did this study on a few medical students and nurses a number of years ago where we said, well, if you want to go on holidays, we're going to do a rectal swab on you. Surprisingly, they agreed. They took it themselves. And the reason we did that is Australia is a low prevalence country for antibiotic resistance. And I think that's a mixture of some restrictions in people. I think it's because our food supply is safe. We don't have imported foods, particularly fresh meats, and we've got a very good water supply, and we can maybe dwell on that later. But basically, these are people who lived in Canberra. Before they went on holidays, we did this rectal swab. And we were looking particularly for E. coli resistant to either gentamicin, which is a group of antibiotics, the fluoroquinolones, which I've mentioned, or the third generation cephalosporins. And a few percent was carrying resistant bacteria before they went. After they came back, 50% were carrying these resistant bacteria. Now, what I thought was the interesting bit, we followed them for 6 months and did another swab every 2 months. Their resistance rates disappeared with time. And none of these people had gone to hospitals or healthcare. These were just tourists, travelling around. Now, what I think actually happens is they were ingesting antibiotic bacteria. This doesn't say whether it came from people or animals, but they're getting it through their mouth. They then carry it in their gut. And when they come to a place like Australia where we've got low levels of resistance, those bad bacteria get replaced by better bacteria that aren't antibiotic resistant. So eventually it washes out. But still, a proportion of them had it even 6 months after we came. And I see this with people who have prostate biopsies. If you have a prostate biopsy, they usually put a needle through your rectum into your prostate and give you some antibiotics immediately beforehand. But as you can imagine, some bugs get picked up on the way and get put in your prostate. And around the world, about 2 to 4% of people who have that end up with a serious infection, including in their blood. Whenever we see a multi-resistant bug in their blood, if we then go and talk to them, invariably they've been in holidays in Vietnam, the Philippines, China or India in the last 6 months. And what I think happens is they actually have these bugs in their bowel. They're given antibiotics often a little bit too early beforehand. The resistant ones get an advantage. They're in high numbers, so when the needle goes through, that's what goes into their prostate. This is a real problem in places like England and Canada, where they've shown a 3-fold rise in the number of bloodstream complications after a prostate biopsy compared to 10 years ago. So this isn't a unique Australian phenomenon. This is happening worldwide, and it's very much related to developing countries and having been there. Well, I think I've probably convinced you antibiotic resistance is bad. Well, I hope I have, because otherwise I've missed the mark here. But that brings up the next issue, which I think is sure of, is what the hell's that got to do with food? You know, isn't it all what doctors do and poor infection control and people? Well, most of it is, okay? I acknowledge that. But I actually think food and water, food is an issue. Water is a major issue, particularly in developing countries. But what's the evidence of food? Well, first of all, I'd come back to this One Health concept. I think there's no doubt that everything goes around. Now, the question is what percentage goes around and all those figures. But my bottom line is I don't think there's zero transmission from food to people. You know, 100% of our antibiotic resistance problem is not due to the food industry, and equally 0% is not due to it. And the point I make is if with certain bacteria like E. coli, which is the commonest bacteria causing infections in people, even if it's 1%, and I think it's more than that, that's still a lot of people that get an infection that got resistance if that resistance didn't need to be there. So, and I'll try and... Now, what's the evidence that food is an issue? Well, I think I've already given you an example of that travel study we did that suggests what goes through your mouth is an issue. This is a study, interestingly, done by a guy, Corpay, who's French, that was in the New England Journal of Medicine about in 1988. And interestingly, this guy was interested in how foods cause cancer. So he wasn't there, but he was looking for markers. And what he did, he took, I think, 10 medical students, probably said, if you participate in this program, we'll let you pass the exam. But anyway, he took 10 medical students and he followed them each day by taking a fecal sample and looking as to what they were carrying in their bowel. And basically, the grey filled-in bit, the top line is the amount of E. coli they had in their stool sample. I think it's per gram per day. You know, it's fairly high, log 6, which is log 6 is a million bacteria per gram of feces. And you can see the top one with the white underneath it was, you know, fairly high, around log 6, log 7, but varied, interestingly. It wasn't, you know, this constant each day. The grey bit is the percentage that were tetracycline resistant. Now, the interesting thing, at day 21, he gave them autoclaved food only to eat. In other words, they only ate sterile food. And what I think is fascinating, within a day, they lost their tetracycline resistant E. coli to large proportions. So very quickly, the amount of bacteria that were antibiotic resistant disappeared very quickly. Now, the dogma is you get your bacteria as babies and you have the same ones all your life and they're specific to you. I actually don't think that's true. I think our travel experiment, plus this sort of data, shows there's a lot of turnover of your E. coli every day in your bowel. Now, this doesn't answer the question as to whether it came from people contaminating the food or animals, but it does show you can actually have a lot go through your mouth. How much is from food? This is a particular person called James Johnson who does studies in the US. And what was interesting about this is he showed that there were populations of resistant E. coli or sensitive E. coli in the bowel of people in Wisconsin. And essentially what was interesting is the resistant E. coli were very similar to poultry E. coli and quite different to the human ones from their genetic markers, implying that a lot of the resistant bacteria being carried in the bowel of people in the US, in this state in the US, seem to be acquired from poultry. One of the things that you'll probably be pleased to think, because I presume there's no chicken producers here, poultry seems to be much more of a risk than pigs, and cattle is the lowest risk for transmission. Not that they don't, but relatively, poultry seems to be much more of a risk. So again, I think this is good evidence that what we get is the thing. This is a study that I and a few colleagues from Europe did a number of years ago, and the bottom line is we looked at the resistance of people with bloodstream infections in a number of European countries and correlated that with the antibiotic usage in people and what resistant bacteria were carried by cattle, pigs, and poultry. And basically, there was a stronger correlation with what people had as antibiotic-resistant bacteria with what was in poultry than antibiotic usage in people. Now, again, that doesn't prove anything, but it says there's an association there that's suspicious that particularly poultry, and then the next order down was pigs, and the next ones after that was cattle. I mean, I think there may be some interesting reasons why cattle might be less of a risk than poultry, but we can maybe talk about that in the question and answer session. I, along with a number of people, have been involved in trying to do something about this. Now, none of us believe that you shouldn't use antibiotics in animals at all. I mean, food animals get sick and they need to be treated, and it's production and economic and all the rest of it. But there are issues about the volumes and what types of antibiotics might be used. And with the World Health Organization, about 10 years ago, what was in fact obvious to me, I was in a committee called JEDICA in the 90s that was set up by the Australian government to look at what happens in Australia. And with the veterinarians that were on the panel with me, what I actually found surprising is their perception of some antibiotics was quite different to me. One antibiotic that we regard as really important is called vancomycin, because we use it for MRSA and things like that. At the time, there was a drug called avaparcin, which is in the same class as vancomycin, being used as a growth promoter in poultry. And the veterinarians weren't all that worried about that, and I thought, why? And it was when I realised it's because they never used those drugs at that time. So from their perspective, you know, this wasn't an issue because it wasn't one of the drugs they prescribe. So what we did, we tried to sort of say, well, we need to put this from a human perspective. How about we list the drugs that we call critically important? And the reason we call them critically important is because if we get resistance to them, there may be little or no choice to treat people with serious infections. And that's quite different to drugs, for instance, that aren't used in people at all, or drugs, for instance, in my view, a bit like tetracyclines that are used, but we've got other options if there's resistant. So lists of these came up, and the first meeting, in fact, was in Canberra in about 2004, where all the classes of antibiotics were categorised as critically important, highly important, important, or not used in human medicine. And the reason for that was to give producers some idea of the relative scale of what, if you're going to put controls on things, what's probably more important. And there's different references. This is on the WHO website. Now, what bacteria are related to food? I think there is some that, in my view, aren't related to food at all. The meningitis germ, the pneumonia germ, the gonococcus germ. Although, interestingly, even with one of those meningitis germs called Hib, it does carry an antibiotic resistance gene called TEM, which is also in E. coli. So even that, I think you can't be absolute about. But from my perspective, these are not related to food. Now, there's some where, in fact, in a country like Australia, with a good water supply, just about all of them are related to food. And that's Salmonella and Campylobacter. I mean, in my view, 90% of whatever resistance we see in people with these infections is related to what has happened in the food industry. Now, there's also another group that are very important human pathogens, E. coli, Enterococcus, and a particular bug called C. difficile, where we don't know. Now, whether it's 1%, 10%, 90%, I don't know. I mean, for E. coli, I suspect it's 10, 20%, or even up to 50%, but the bottom line is we don't know. But there is also no doubt that it does come across to people from food animals. It's just the quantity. There are other ones that I used to think had nothing to do with food animals, golden staph, Staph aureus, but more recently they've found farmers, particularly with pigs, are getting MRSA directly from the animals, although there's not evidence that goes through the food chain yet via foods to the general public. The bottom line is that, yes, it is an issue. Now, what about some specific examples? E. coli and quinolones, I think, are a good example. We never had approved for use a group of antibiotics called fluoroquinolones, enrofloxacin, in Australia in food animals. We are the only country. The end result of that is, in my view, we have no resistance in any isolates from food animals in this country, and our resistance level in people is much lower than just about every other country in the world. And I think that does have something to do with what we're doing better in the food industry here. And Spain is a good example. Children even have a lot of resistance, even though you don't give this to children because it affects their cartilage and bone. So they're getting it some way. And this is a study we published in an American journal a couple of years ago. And basically that red dot is Australia. We have the lowest resistance in the world for this group of antibiotics. And I think that's to do with not importing meats from overseas or fresh meats from overseas as well. Ceftiofur, which is a third generation cephalosporin, is used in this country, and I think it's a concern because those ESBL and those multi-resistant things can be driven and developed by this. So this is one antibiotic we do use in this country that I think we need to discuss. What do I think is prudent use of antibiotics in food animals? My personal view is we should not allow antibiotics to be used for growth promotion. You know, if the purpose of antibiotics is to make an animal get a bit faster, a bit quicker and eat less feed, my view is that's a misuse of antibiotics. It causes resistance for marginal or no economic grounds, and we shouldn't do that. And most countries are moving towards banning that. However, the other issue that I think is a major one is prophylaxis, this continuous preventative use of antibiotics. If they end up getting used in the same amounts, the same way as growth promotion, well, while it's not called growth promotion, it's the same effect. And my view is that we need to find other ways to prevent disease other than continuous antibiotics, be it vaccines, be it different feed formulations, be it, the way because I don't think it's sustainable anyway because of antibiotic resistance. It's hard to see if you use these antibiotics all the time how they can continue to work because resistance will be intrinsic in the animal industry as well. I also think there's some certain critically important antibiotics. There's some that are not currently used in the food industry at all, such as carbapenems. I exclude cats and dogs from this because they're almost honorary children. I'm talking about food animals here. I actually think there's certain ones we shouldn't use. Now, in Australia, that's already a case. The avapars and glycopeptides are effectively banned. Enrofloxacin and fluoroquinolones are effectively banned, and we don't use them and haven't used them. I think third generation cephalosporins are another one, and carbapenems, for instance, is another one where I think we should never use that because they are drugs where we really need for people where there's nothing else. And there's a few others on that list. Do I think we can get a win-win situation? Yes, I think we can. I think if we get substantially less use of antibiotics in food animals, we will lower the risk to people. And some of this is commercial as well as public health, but I think it also gives better marketing opportunities for our exports. I mean, we already have low resistance relatively in our animals, particularly free-range or grass-fed cattle. I can't speak for cattle feedlot. But we've got, in my view, a marketing opportunity because this is on the radar of America, Japan, all the countries I would think we were going to export to, and I think this is going to become more of a trade issue. So my view is if we can improve it, particularly at little cost, not only is that good for human health, it may be good for the country economically. And also I think it means if we're using less antibiotics, when animals get sick, the simpler antibiotics will work for the animals that are sick as well, instead of having to use these last resort ones. And I think, the other thing we need is harmonisation of international rules. Now, Codex is one of those that moves at a glacial pace, but again, I know this is on the agenda with WHO, which has input to that, and other things. So my own view is this is changing, and from what I can see is major supermarkets in developed countries are actually putting this in contracts for the products that they produce. And my own view is we need to be very strict in what we allow imported into this country, because I do not see why I think we should have rules about the quality of our water and what we do with our food animals, with drugs and everything else. But there is absolutely no point in then letting imports come in that don't have to follow those rules, or we don't do any testing to ensure that they've got this, that they comply. Because otherwise we're giving our own country a competitive disadvantage. That's an issue I've so far lost with the federal government, but I'll keep trying. Because, for instance, things like apples, if we import them from China, some of those are sprayed with an aminoglycoside called gentamicin. which is a last resort antibiotic. The thing about gentamicin, even if you autoclave it, it's still active. In other words, that apple pie will have active antibiotic in it, yet we do no testing. They tell us they don't use it, we believe them. Well, I've got a slightly more sanguine view, I think. What can the cattle industry do? Well, my own view is avoid antibiotics unless it's essential. I think don't use critically important antibiotics, especially the third generation cephalosporins, which I think is the major risk to, in my view, to what we do. We already don't use fluoroquinolone, so that's not a problem. I think we need to prevent infections, because if you prevent them by whatever means, then you don't need to give animals antibiotics anyway. I think we need to control the use of contaminated water, because I think that's a major vehicle for spreading these bacteria and resistant bacteria as well as sensitive ones, because sensitive ones can cause disease as well. And I think we need to optimise animal movements, because a lot of this is a stress on animals when they're put together and moved around. And I'll finish up again. I think this is a One Health issue. We've all got our own sectors and we all tend to stay, but they all do move around and come around, and that includes internationally. So thank you.